pointer? What's the pointer? Can you change the slide from here? Okay. Very good morning to all of you. Thank you to the organizers for the opportunity to speak on EBUS scope, the similarities and differences, and how to choose the correct scope. Most of the times when we were training, we never had the opportunity to speak on hardware, understand the hardware, and choose the hardware. So it's very important to understand these as well. So today's discussion would include a brief history of EBUS, the various EBUS scopes which are available, the processors, needles have already been spoken of, what is the comparison between the available scopes, and how do you make the right choice, and what the future holds for us. So the convex probe ultrasound was developed for sampling of the mediastinal lymph nodes and lung lesions. As most of the concepts in bronchoscopy, even this was imported from gastroenterology, where they started sampling the paraesophageal lesions under the real-time guidance. The first description comes from Pedersen and colleagues, which described the usefulness of linear EBUS in sampling mediastinal lesions. And then Yasufuku and colleagues demonstrated the high diagnostic yield with convex EBUS in sampling of the mediastinal lesions. If we look at the history of TBNA, it has evolved magnificently. In 1949, it used to be done via a rigid bronchoscope. Eventually, the conventional TBNA by Koppenwang and colleagues. And then came in the EBUS, followed by EUSB FNA, and now we are proceeding to EBUS cryobiopsies as well. So just the next question before we go into more details of the various scopes. All of the following frequencies are available on convex probe EBUS except it's the 20 megahertz is the error there. So that's the right answer. So you have two forms of EBUS scopes available. You have the radial EBUS scope and the convex scope. One slide just explaining the difference between the radial EBUS and the convex probe or the linear EBUS. The transducer is a rotating mechanical transducer for radial EBUS. It provides a 360-degree view along the long axis of the scope as compared to the linear probe EBUS, which is an electronic transducer providing a 60-degree view parallel to the long axis of the scope. It's a 20 megahertz frequency for the radial EBUS compared to the 5 to 12 megahertz frequency for the linear or the convex probe EBUS. The tissue penetration or the depth of penetration is more or less the same. The image quality is extremely good with both of them. The advantage which the convex probe EBUS has over the linear probe EBUS is real-time imaging and sampling and a possibility to use the Doppler to identify the vessels. We'll be mainly concentrating on the linear or the convex probe EBUS. As of now, we have three companies which have the linear or the convex probe EBUS. Olympus was the first one to launch the convex probe EBUS. The other two are Fujifilm and Pentax. As far as the Olympus EBUS scope goes, there are two scopes which are available. The earlier one was the 180 series scope, and the newer one which is launched is the 190 series scope. More or less, both these scopes have a similar design, except for the fact that the newer scope has a lesser degree of oblique forward viewing, that is 20 degrees, and it is a thinner or a slimmer scope where the ultrasound transducer, the tip diameter is around 6.3 millimeter, and it has a greater forward angulation. It's around 160 degrees. The advantage of this greater forward angulation is with the help of the 19 gauge VisiShot needle, it makes it easier to sample the station 4L and the station 10R and 10L. So that's an advantage which the forward angulation provides. So these are the key differences between the two scopes. You have the shorter distal rigid tip with the newer 190 series scope. It has a greater forward angulation and lesser degree of forward oblique viewing. The Olympus scope comes with the processor EU-ME2. The other processor which is available is the EU-ME3, which is newly launched. The advantages of the EU-ME2 and ME3 is it has enhanced B-mode imaging. It is compact. It has a greater resolution. It has features like elastography, which helps to identify the area of the node which needs to be sampled. It is cost effective because it can be used with and shared with other departments, including gastroenterology, and you can do all your procedures, be it EBUS, USB FNA, or Radial EBUS with the same processor. Between the EU ME2 and ME3, the ME3 is a single hardware. You did not have different hardwares if you're considering elastography. You can always upgrade only with a software upgrade. Coming to the Fujifilm scope, which is the EB530 US, the difference between these two scopes is using a Fujifilm scope is almost using your normal bronchoscope. The forward angle of viewing is 10 degrees. It's almost as close to 0 degrees possible. It has a greater depth of field as compared to the Olympus scope. The angulation is 120 degrees forward and 90 degrees backwards. So this is the view which you get, the top view, when you are intubating the patient with the EBUS scope. It's as good as intubating with a normal bronchoscope. Obviously, the clarity in the vision is a little better as compared to the Olympus scope. So it gives you a very good endoscopic as well as an ultrasound quality. The processor is the SU1 processor. It has all modes available, including elastography, color Doppler, harmonic imaging, which improves the resolution of the tissue, reduces the signal to noise ratio. It can be used for GI pulmonary procedures. Only drawback is you cannot use a radial probe EBUS with this processor. It needs a different system. You have the PB2020 ultrasonic transducer along with the SP900 ultrasonic processor. Advantage is you can use a standalone system for radial EBUS, but you can't use the SU1 processor for radial EBUS. If you come to the Pentax scopes, you have two scopes available. The newer Pentax scope has a 2.2 millimeter working channel like the Olympus scope. The advantage of the 2.2 working channel is you can use the 19 gauge needle, which is useful for doing your EBUS cryobiopsies. If you're using a scope with a 2 millimeter working channel, you can't use the 19 gauge needle because the outer diameter of the 19 gauge needle is 2.1 millimeters. The direction of view, it's a little more difficult to use because it has a 45-degree forward oblique viewing as compared to the Olympus and the Fujifilm. Now, big disadvantage is you need a compatible video processor and a compatible ultrasound processor as well. Because you can use the ultrasound scanner as a routine ultrasound, but most ultrasound scanners cannot be used with the Pentax system. So it utilizes more space in your endoscopy suite and also needs PCP and DTACT. We'll compare these in the future, this thing. Needles already covered by Dr. Loveleen. What is important to note is most needles which are available in the market can be used with an Olympus scope. Olympus has not outsourced for needles, but if you're using the Fujifilm or Pentax, you will have to rely on outsourced needles for their use. So this is the head-to-head comparison between Fujifilm, Olympus, and Pentax. If you look at the important points, there is a greater field of endoscopic view with the Fujifilm. It's around 120 degrees compared to 80 degrees with the Olympus. The viewing direction, it's only a 10-degree forward oblique viewing as compared to 20 degrees with the newer Olympus scope and 35 degrees with the previous Olympus scope. Pentax, a little more disadvantage, 45 degrees forward viewing angle. You just imagine you're walking, instead of visualizing straight, you're almost walking looking upwards. That's the disadvantage with the oblique viewing. The distal end diameter is the least for the Olympus 190 series scope. It's 6.3 millimeter, and it is much larger for the Pentax and the Fujifilm scope. The advantage of Olympus newer scope is 160 degree forward viewing angle. The only thing is Olympus scope is a hybrid scope. You have the CCD, that is the charge coupled device, along with the fiber scope. That is why the quality of the image is a little poorer as compared to the Fujifilm or the Pentax scope, where they use only, it's a pure video scope as far as Fujifilm and Pentax goes. So head-to-head comparison, why am I comparing with Olympus? Because most of the scopes which are available is probably Olympus. Most of us have probably trained also on Olympus. So if we compare Fuji scope with the Olympus, points favoring the Fujifilm scope would be a better endoscopic image quality as compared to Olympus. However, the negative aspects would be the rigid distal tip is longer with the Fujifilm scope. The distal end occupies a significant extent of the endoscopic image. It is a smaller instrument channel, decreased up angulation capacity. You need a separate processor for radial EBUS and a separate keyboard. And if you compare Olympus with Pentax, there is no doubt that Pentax gives you the best ultrasound image quality and an excellent endoscopic image quality. However, it has a longer rigid distal tip. It is much thicker. It's almost 7.3 millimeter distal diameter, which adds to patient discomfort and may require greater amounts of anesthesia. It has a steeper direction of view. The needles are outsourced. You do not have a radial EBUS available with Pentax. It occupies much more space in your endoscopy room. The presence of a dedicated ultrasound system requires PCPNDT certification in most states in our country. There is no picture-in-picture available, and not all systems are serviceable in the country. So, coming to the most important point, which is the scope that you would want to choose if you're buying a new one? The most important thing is the ease of use and the comfort of use. As far as the operator perspective goes, ability to sample most of the lymph node stations. As far as patient comfort goes, minimal requirement of sedation and doing a comfortable procedure. Smaller the scope, better is the patient comfort. Also, the importance of the smaller scope is if you are doing a nasal EBUS. In situations where there is limited mouth opening or patient has undergone orofacial surgery, and if you want to do a nasal intubation, it is difficult using the Pentax scope or the Fujifilm scope. The newer generation Olympus scope, which are smaller diameter, would be easier to pass through the nose. Also, if you're doing a EBUS through an endotracheal tube, the smaller scope would be more advantageous. Also, you need to consider what is available already with you in your endoscopy suite. So if you have a particular company's processor and an ultrasonography console, it's easier to probably buy the same scope. The characteristics of the EBUS scope also matter. The direction of forward viewing angle, the flexibility of the scope, the distal end size, the diameter of the working channel, the quality of the video, the endoscopic image, and the ultrasonographic image. All of this would also be the points of consideration. The cost of the scope also makes a big impact in making the decision. The post-vending services or the assistance from the manufacturer is equally important. If you have a scope damage or a malfunction, the post-marketing services play a very important role. So most of the times the final decision depends on a compromise between these options, and you have to make a choice based on what suits you the best. Just a couple of last slides. What the future holds, there are a few limitations with the existing the convex probe EBUS. The difficulty to navigate the scope in the upper lobes or the narrow right middle lobe, the forward viewing angles. All these limitations has led to more research into development of thinner convex probe EBUSs, which will have a more favorable forward viewing angle, smaller distal tip, and a greater range of angulation. There is a study where they have, it's still under evaluation, something known as the thin convex probe EBUS, which has a 20-degree forward angle viewing. The diameter of the insertion tube is 5.7, the distal tip is 5.9, and the angle of upward flexion is 170 degrees. It's still not launched. Maybe with more modifications, you will have it available in the near future. It may be also useful for pediatric EBUSs. And one small take-home message. So there is no head-to-head comparison between what scope gives you a better yield. The most important thing is it should do the job. It should give you adequate tissue, it should give you adequate yield, and it should minimize the complications. What are the complications which are worried about? One is a negative EBUS, and second is damage to the scope. So if you do your learning properly, you reduce the complications, and that is what should be the final aim. Thank you.